fellow lectures. So today I get to talk about hematology, monoclonal antibodies, as well as I get to tack on an ever-growing area of CAR T or cellular therapies. Feel free to ask any questions via chat or verbally as we go along. It should be more interactive, but I do have quite a bit of content to get through. I do have some objectives for the slides. We're going to review the basics of monoclonal antibodies. We're going to identify targets and mechanisms for their utility for hematologic disorders. We're going to review dosing toxicities as well as pearls for various mAbs. We're going to summarize the manufacturing, the available products, and the toxicities of CAR T-cell therapies. We're also going to review UW's CAR T use to date, including efficacy and safety. First up, just an overview of monoclonal antibodies, which I think we're all probably pretty familiar with at this point. They evolved from a research tool to a pharmaceutical agent over the past few decades. They have variable and constant regions. They have light and heavy chains, and they have complementary determining regions, or CDRs. And the general structure is here on the slide, and we'll talk about how they are augmented or adjusted to be useful in clinical practice. Quickly, regarding nomenclature, it's important to know that drug names aren't just nonsense that are developed by drug companies. There is some utility to how things are spelled and why it is spelled in a certain manner. With monoclonal antibodies, that isn't any different. These proteins are differed by the type or how human the proteins are within the structure. Those that are murine amino acids are entirely non-human in protein, typically have the nomenclature of an O within their name, like miromamab. Whereas you can go all the way down the slide, going from a chimeric product such as rituximab with XI in the name. Humanized monoclonal antibodies have ZU, such as alemtuzumab, and then fully human proteins or fully human amino acids will have a U in them, such as adalimumab. So it's kind of a quick shorthand, and of course that also helps correlate to how likely you are to have a reaction with these products. The more human the protein, the less foreign the protein, and therefore less chance for reactions such as the really classical infusion-related reactions that we see with rituximab. Monoclonal antibodies are highly effective tumoricidal products. They have several mechanisms by which they get that done. I've got a nice graphical depiction of that here on the right hand of the slide. And we'll kind of use these mechanisms in shorthand as we go through the agents. But they can have receptor or ligand binding, whether that's antagonizing a receptor or triggering signaling of that receptor. So it can kind of be a positive sign or a negative sign for that receptor. They can lead to complement-mediated cytotoxicity, which is kind of a secondary mechanism by which they can function. You can have antibody-dependent cellular-mediated cytotoxicity. Notice I got some things in the way, which is the far right-hand side, where you can have these antibodies bringing in the activity of T cells in the graphical example here, and one of the mechanisms for rituximab. And then more contemporarily, we can have these monoclonal antibodies linked to something such as a cytotoxic payload that can be delivered specifically to a tumor that shows that receptor on its surface. So antibody-drug conjugates it would be a good example of this. Jumping into the agents, you have to, of course, start with the CD20 agents, specifically rituximab as kind of the classic. In the graphical depiction on the right-hand side, we do have kind of some of the CD20-directed monoclonal antibodies and how they differ and how they bind or where they bind within that structure. So you can see kind of a difference in where that binding affinity is, but we'll kind of treat them as a class-based effect, even though in practice it's really not the case. These monoclonal antibodies are directed against CD20 antigens on B lymphocytes. They bind to the antigen, activating complement-dependent as well as antibody-dependent B cell cytotoxicity. They can also activate neutrophils and produce free radicals or free oxygen radicals. Some pharmacokinetic interests, they can cause B cell depletion for up to 6 to 9 months in the example of rituximab. And the half-life is relatively long with almost all of these monoclonal antibodies, But as an example of that, the elimination half-life here for median is 20 to 30 days with rituximab. Indications, of course, FDA labeled are going to differ from what we use in clinical practice. There are many off-label indications for rituximab, but classical ones such as all the the lymphomas. Obinutuzumab with FDA labeling for CLL as well as follicular lymphoma, and ofatumumab CLL. Dosing regimens are going to differ based upon the product, but of course rituximab has many different regimens, many different dosing. Whether it's weekly or whether it's a monthly dosing regimen really depends upon what we're treating and what we're doing. But the common dose, of course, is 375 milligrams per meter squared IV. And obinutuzumab, calling it out as a special product here, has that kind of day one, cycle one loading kind of short dose, 100 milligrams, followed by 900 milligrams on day two, trying to decrease the risk of infusion-related reactions, and then goes to a gram or 1,000 milligram dosing thereafter. Toxicities, these drugs are not without toxicities, of course. There are black box warnings for these products, such as infusion-related reactions with the rituximab product, as well as its biosimilars. Severe mucocutaneous reactions as a black box for rituximab. Hepatitis B reactivation is the reason why we check Hep B labs prior to giving these products, as well as a black box warning for progressive multifocal leukoencephalopathy or PML. Some other toxicities here, nausea, vomiting, and diarrhea are going to always come up on almost all of these medications just because of the way that they're studied in clinical practice. Dizziness, headache, pruritus, and infusion-related reactions. There is supportive care requirements for Tylenol and Benadryl at least for pre-medication for these products. And again, you want to be giving the first dose in an area where treating someone for infusion-related reactions may be possible. Just segueing briefly, talking about the CD20 targeted agents in the biosimilar era. So biosimilars, of course, are not generics, but protein products that are considered biosimilar, bioequivalent. These are things that are now, of course, coming more prevalently in the treatment arenas. We do have biosimilars here at UW, and I just wanted to provide some evidence for why these products are useful. This is a really nice example of R-CHOP, or standard Rituxan, versus a biosimilar product of Rituxan called IBI 301. So this is an R-CHOP versus IBI 301 CHOP for a diffuse large B-cell population. These products are designed to reduce cost and provide similar efficacy and safety. And of course, many have been proven in the United States, and we are using them here at UW Health. In this paper, you can kind of look at the top line numbers for adverse events on the right-hand side on table 4, and then secondary efficacy points on the left-hand side. But what they found in the study, just to put an underline on it, is that they were not found to be non-inferior for efficacy, as well as similar toxicities or adverse events. And you can kind of see that as you look through these products. So we do consider these, for all intents and purposes, interchangeable. And it's really driven by insurance as to what product, which biosimilar a patient is going to receive at UW Health. I alluded to it a little bit earlier, but antibody drug conjugates is something that is becoming more prevalent in practice, and we're going to have several that we go through today. I think the biggest and the most poster child, at least for a hematology population, would be brentuximab vedotin. This is an antibody drug conjugate, which I have a graphical picture in the upper right. This has a chimeric IgG1 monoclonal antibody that is specific to CD30, so it floats around and tries to seek out CD30. It's got a protease cleavable linker that covalently attaches the two components, and then the payload is MMAE, which is a microtubule disrupting agent, so kind of a more classical chemotherapy product with a directed monoclonal antibody attached to it. The mechanism, again, it seeks out CD30, binds to the cell, forms a complex in which is internalized, and then that protease cleavable linker is cleaved, where the MMAE is released, and it can induce cell cycle arrest in the G2 or M phase and lead to cell apoptosis. These CD30 products, brentuximab is approved for the labeled indications below: anaplastic large cell lymphoma, Hodgkin's, which is of course a big player, Hodgkin's after auto, as well as CD30, mycosis fungoides, and peripheral T-cell lymphoma. Dosings here on the slide, 1.8 mg per kilo IV day 1 of a 21-day cycle. And there are dose adjustments recommended for mild hepatic impairment, and avoid for severe liver toxicities. There's a black box warning for this product for PML, or progressive multifocal leukoencephalopathy. And I've got some non-black box warnings on the slide as well. Big player being neuropathies is a big issue with these products. And you will see a lot of these, even if they're monoclonal antibodies that are directed, you may see some of these classical chemotoxicities such as thrombocytopenia or count suppression because of these cleavable MMAE or the drugs that are being delivered. Moving on to CD33 targeted products, gemtuzumab is another good example of an antibody drug conjugate. Again, this is a monoclonal antibody with a protease cleavable linker. In this case, it's an IgG4 monoclonal antibody that is targeted CD33. And then you have a cytotoxic kalikiamycin derivative as your payload that you're delivering. The mechanism is going to sound very similar. It is directed against CD33, but in this scenario, it binds to CD33, resulting again in an internalization of this antibody-antigen complex, subsequently releasing the kalikiamycin in the same manner that you had with brentuximab. And this leads to DNA binding, double-strand breaks, and cell cycle arrest and apoptosis. So again, a nice way to deliver a cytotoxic product to a more specific cell population. Dosings here on the slide. The FDA labeled indications are newly approved and relapsed refractory CD33 positive AML, as well as we just had one, I think, a couple weeks ago for an APL or acute promyelocytic leukemia, where we use that. The dosings on the slide, induction dosing 3 mg per kilo days 1, 4, and 7. And then it's also can be used in consolidation for those AML patients. And then the monotherapy dosing is on the slide as well. Hepatic toxicity, kind of a spoiler for the next slide, but you're going to be holding for VOD or LFT abnormalities. And VOD, sorry, is veno-occlusive disease of the liver. This is a really interesting example of a product that was actually pulled from the market and then reintroduced. So this product was approved way back in 2000. It was actually withdrawn, quote unquote, voluntarily by Pfizer in 2010, and you can actually see the kind of press release up above. And then it was reapproved back in 2017. This product has a black box for severe hepatotoxicity, including veno-occlusive disease of the liver. This is one of the reasons why it got pulled from the market. They also had a confirmatory study trying to confirm its efficacy, which led to it being pulled from the market. They didn't see any improved outcomes, and they did have this hepatotoxicity. They looked a little harder at this product. They studied it kind of in a different population, and they were able to derive, that specific population, specific indications that it now has from an FDA labeling perspective. Other toxicities are on the slide as well. It's kind of tough to tease out what might be drug versus kind of the disease population. When you think about AML induction therapy, you're thinking a lot about these infections, these fevers, these hemorrhage. But the severe hepatotoxicity, including increasing the risk for VOD going into a stem cell transplant, as well as outside of stem cell transplant settings. So this is kind of a drug that does come with that as baggage. Taking a step towards CD19 directed therapies, these were drugs that were recently approved in the last 3 or 4 years. Prior to that, we did not have anything directed towards CD19 outside of CAR T-cell therapy. This is another antibody drug conjugate, loncastuximab. This is a drug conjugate that is targeting against CD19. It's conjugated to a beautifully named SG3199. This is your payload, which binds to DNA minor grooves, causing DNA cross-linking and cellular death. This is approved for relapse refractory large cell lymphoma. And your dosings here on the slide, with the caveat being for those with severe obesity, BMI greater than 35, dosing weight should be adjusted. So I will call out kind of weird dosing as I see them go along. The dosing is on the slide here, cycle 1 and 2. It's kind of double dose, 1.15 mg per kilo on day 1 of a 21-day cycle, whereas the dose is reduced cycle 3 and beyond. And this also requires corticosteroids for the day of and the day following therapy. Toxicities are on the slides. I did call out grade 3 and 4 hematologic toxicities. We expect some pretty bad hematologic toxicities here. Grade 3 and 4 anemia is 12%. Neutropenia, grade 3 and 4 is 32%, so pretty decent rate there. And then you have a decent amount of hepatotoxicity as well. This is a nice product to have in our back pockets for those relapse refractory folks. Between it and its cousin, tafasitamab, again, another CD19 directed therapy. This one's brand name is Monjuvi. This one is actually just a monoclonal antibody, so no drug conjugate. This is targeting CD19. This causes apoptosis via antibody-dependent cytotoxicity as well as phagocytosis. Approved again in the relapse refractory DLBCL setting, and the dosing is relatively complex here on the slide. But the big thing to call out here with tafasitamab is that it is FDA labeled and approved for those products be given in combination with lenalidomide. Starting dose of 25 milligrams, days 21 through 21 of a 28-day cycle, which will sound very familiar for those who have dealt with multiple myeloma so far. That study was done in combination, though if you look down below on my toxicity list, relatively toxic in combination here. Neutropenia, thrombocytopenia, anemia are all relatively high rates. Serious infections were noted to be in 26% of patients. 73% of patients experienced any infection during the clinical trial, and 24% of patients had fevers. That's a decent amount of toxicity in a relapse refractory DLBCL setting, though they did note that in those who required lenalidomide holds or stopping of the dosing, the incidence of grade 3 and 4 adverse events reduced from 70% to 29%. So I have seen in clinical practice, though I don't work in clinic too much anymore, that this is one of the preferred regimens for relapse refractory DLBCL in those who otherwise are not terribly fit for therapy, to actually just give tafasitamab no lenalidomide, kind of see how they do and potentially add the lenalidomide back after a couple cycles. But I have seen that in clinical practice a couple different times by our hematology providers. I did want to call out one special case here, not technically a monoclonal antibody, but it is a hematologic product. It is targeting a receptor like we're talking about with almost all the other products here. This is tagraxofusp. Tagraxofusp is targeting CD123. It's a fusion protein of IL-3 fused to a catalytic or translocation domain of the actual diphtheria toxin. It's kind of tough to see on the slide in the upper right-hand side, but you have that IL-3 to diphtheria toxin that is linked to a cancer cell. The IL-3 receptor will internalize that. It will cleave off the diphtheria toxin, and then that will lead to cell cycle protein synthesis, death, and cell death. So very much in the same vein as a monoclonal antibody with a drug antibody conjugate, but not using a monoclonal antibody structure here. This is approved for blastic plasmacytoid dendritic cell neoplasm. The dosing is a bit odd, and it's on the slide here. 12 micrograms per kilo IV on days 1 through 5 of a 21-day cycle. Pre-medications are significant here. We're talking about Benadryl, famotidine, Tylenol, and at least 50 milligrams of methylprednisolone or equivalent corticosteroid. It requires inpatient administration at least for the first cycle. It's got this interesting caveat about serum albumin dosing, requiring a patient's serum albumin be at least 3.2 grams per deciliter prior to the first dose. The big driver of that is, of course, below, where you see a black box warning for capillary leak syndrome in at least 55% of patients in the clinical trials. If you look through the rest of the toxicities, they are also quite significant. Hepatotoxicity in up to 90% of patients. Decreased albumin, 77%, of course. Pancytopenia, grade 3 or 4. We're talking about 31 to 53% of patients. fever in 43%, again, capillary leak and kind of this reactive process, as well as hypersensitivity reactions in 46%. And I wanted to call out this product because working in hematology, you may see quite a bit of this with regard to inpatient administration and the requirement thereof. We don't have that many great therapies for blastic plasmacytoid dendritic cell neoplasm. I think we've seen, Mike can correct me, but at least one patient, maybe two patients so far on B66 with this product. And it doesn't have kind of this novel mechanism of action. So I did want to call that out. Moving on to one of my favorite areas, multiple myeloma and the multiple myeloma mAbs, which did not exist prior to, I want to say, 2015. So we've seen a decent amount of evolution here with regard to clinical practice. First up is kind of the poster child, daratumumab. This is a IgG1 human antibody against CD38. It induces cellular-dependent cytotoxicity, antibody-dependent cellular cytotoxicity, as well as antibody-dependent phagocytosis. Approved originally in the relapse refractory setting for multiple myeloma, now has FDA approvals for the newly diagnosed setting. Dosing will differ based upon the approved regimens, but pre-medications are going to be required. Talking about dexamethasone, H2 antagonists, Tylenol, and Benadryl. And we have had quite a bit of success with using montelukast with a 5-day run-up prior to cycle 1, day 1. And this was really a remnant of our previous product, the IV dosing, which I've got it here on the slide, 16 mg per kg weekly. And the dosing would vary. But the biggest thing and the most contemporary thing is using a co-formulated 1,800 milligrams with 30,000 units of hyaluronidase as a co-formulated subcutaneous product, which is kind of taken over for IV daratumumab. It's sort of in the vein of when rituximab was first approved. We used it, but we didn't have the best sense for how to use it and how to use it successfully. This daratumumab was approved again back in 2015, but since then we've learned, we've gone from an area where we were giving the first dose of daratumumab over 6 to 8 hours or splitting it over several days to ensure that these infusion-related reactions weren't problematic. Now we've got this co-formulated product that's subcutaneous that has made it a lot easier for a lot of patients to receive these therapies. So we're kind of evolving our use of the same agents to be more successful. Toxicities here on the slide. Again, decent amount of hematologic toxicities, grade 3 to 4, anemia in 14%, thrombocytopenia in 16%, upper respiratory infections 24%, and of course infusion-related reactions. And then calling out interference with cross-matching and RBC antibody screenings with any of the CD38 products, which we're going to talk about the other one here in a moment. I did give you a kind of a primer for this, but daratumumab, again, was FDA approved originally as an IV product, which was relatively cumbersome to use. A formulation of the sub-Q with hyaluronidase has since come onto the market. And they did a really nice study in the Lancet Hematology back in 2020 looking at sub-Q versus IV and how that looks from a toxicity as well as efficacy perspective. What they found was non-inferior efficacy as well as pharmacokinetics and improved safety profiles. So on the upper left-hand side, you had the concentrations of the products, IV versus subcutaneous. And then they also looked at body weight subgroups, and they found no statistically significant difference between them. On the right-hand side, you'll see progression-free survival as well as overall survival in sequence, PFS on top. And they found no statistical difference between them. And then you'll also have on the bottom left-hand side actually a mean satisfaction with therapy domain score, which argues that patients were more satisfied with the subcutaneous dosing of daratumumab. All this is to say that we were able to find a product that didn't require 8+ hours of chair time in the infusion center. I believe it's a little more expensive, but it does make patients' lives and our lives as practitioners a little bit easier. So it's nice to have these evolution of products. Its cousin is isatuximab. I'm not sure if we use this regularly in practice. I don't believe we do here at UW Health. IgG1 derived monoclonal antibody, again targeting CD38. So again, very much a cousin of daratumumab here. Approved only in the relapse and refractory setting, requires the same pre-medications here with steroids, Tylenol, Benadryl, and an H2 antagonist. And the dosing's here on the slide with weekly ×4 for the first cycle and every other week thereafter. This, of course, is an IV product, not subcutaneous, a little more cumbersome from a patient perspective. And I would say a little more aggressive on the hematologic toxicities as well. You can see the rates here on the slides, but any grade anemia, any grade neutropenia, any grade thrombocytopenia were at least 84%, if not higher. Grade 3 to 4 anemia is up to 30% as well. And you still have, since it's CD38 directed, that interference with cross-matching and RBC antibody screens. Elotuzumab, another product, monoclonal antibody that was approved probably, I think it was 2017, 2016, working in a different mechanism, targeting signaling lymphocyte activation molecule family member 7, or SLAMF7. This activates NK cells and causes antibody-dependent cellular cytotoxicity. It's approved only in the relapse refractory setting. Your pre-meds are there on the slide, and it is a weekly dose again for cycles 1 and 2 and every other week thereafter. This one has kind of a more novel toxicity profile. We're looking at effects on heart rate and blood pressure, as well as a pretty decent diarrhea. And then you still have some of those hematologic disorders that we would tack on, that we would kind of expect. There are neutralizing antibodies that were developed in about 66% of patients who received elotuzumab. So that is kind of a consideration or a concern in those patients. I have seen patients at UW Health receive this product, but I would say it's quite a bit down the line with regard to where our hematologists are selecting it for patients. Then we come to a product that was approved a couple of years ago with a novel target mechanism of action. This is a humanized antibody drug conjugate against B-cell maturation antigen, or BCMA. This is only approved in the relapse refractory multiple myeloma setting. The dosing is here on the slide, 2.5 milligrams per kilo, day 1 of a 21-day cycle. And I'm going to call out its kind of novel toxicities here, or requirements. So it does require ophthalmologic evaluations, which are visual acuity and slit lamp evaluations at baseline prior to each dose. So a reminder, this is dosed every 21 days. And for any scenario where you have worsening ocular symptoms. These patients are required to use preservative-free lubricant eye drops, as well as avoid contact lenses if possible. And then specific dose reductions are within the package insert in LexiComp for anyone who's having corneal toxicity. As you can guess, with regard to the toxicity profile here, blurred vision, relatively high, decreased visual acuity in 53% of patients, epithelial keratopathy in 71% of patients. So if anything, this is really the eye medication, the really quite significant eye toxicities here. It does have some, again, expected hematologic toxicities, pancytopenia, and relatively high, but the big highlight here for belantamab mafodotin would be all of these ophthalmologic evaluations as well as toxicities. Moving on, going back to DLBCL, we have polatuzumab vedotin. This again is an antibody drug conjugate. This has CD79B as its antibody target and an MMAE microtubule disrupting agent as its payload attached via a crosslinker. This has a dosing here on the slide. It is FDA approved in combination with bendamustine and rituximab, though I will say again, in those folks who are not terribly fit, I have seen this medication used as a single agent, despite what the FDA labeling is. So holding the bendamustine and rituximab, because at this point, these patients have seen quite a bit of rituximab as well. Toxicities are here on the slide. I'll point out peripheral neuropathy being pretty significant. Hepatotoxicity, pretty decent rates, but of course, the highlight here is the neuropathy, as well as an increase in renal dysfunction or an increase in serum creatinine. But this is a product that is being used more commonly for DLBCL patients. And we're coming towards the end of our monoclonal antibodies. This is a product that we don't use, I would say, very commonly. Inotuzumab ozogamycin, again, is an antibody-drug conjugate targeting CD22. We've seen kalikiamycin as our drug payload before. So this is a kalikiamycin product where kalikiamycin, after being internalized and cleaved, binds to the minor groove of DNA to induce double-strand cleavage and cell cycle arrest and apoptosis. This is approved for relapsed refractory B-cell ALL. Dosing is here on the slide, relatively complex. Pre-medications are required, steroids, antipyretics, and antihistamines. And you really should be cytoreducing these patients, and labeling says as such, to less than 10,000 blasts. They recommend hydrea, steroids, and rifaximin as a method by which to get there. We do have a black box for hepatotoxicity, including delayed VOD during stem cell transplant. So if you receive inotuzumab early before your stem cell transplant, even if it's weeks prior, it does increase your risk for veno-occlusive disease post-stem cell transplant. And it actually was found to lead to higher post-stem cell transplant non-relapse mortality, which is, of course, not one of our goals here. Toxicity includes bone marrow suppression, but also a big, as you would have guessed, increase in liver dysfunction. It can even lead to bone marrow failure in some patients. We're going to close out the monoclonal antibody section with the bispecific T-cell engagers, or the BiTE therapies. I've got two as an example, but this is blinatumomab. Blinatumomab, we'll talk about in the next slide, is going to be an anti-CD19 and a CD3 bispecific engager. Here you see the kind of the two sides of it, one engaging the cytotoxic T cell and one engaging the cancer cell, bringing them closer together and leading to, number one, T cell proliferation, but number two, apoptosis of cancer cells through serial lysis. This is approved in the relapse refractory B-cell ALL population, or also in those patients who are MRD positive, but don't have a significant disease burden outside of MRD positivity. Dosing's rather odd. I'll go first with kind of the relapse refractory setting. Cycle 1, 9 micrograms per day as a continuous infusion for 7 days, and then doses escalated to 28 micrograms daily thereafter, again, as a continuous infusion. So logistically, you're talking about patients being hooked up to a pump for 4 weeks on and 2 weeks off for our dosing. If these patients are just MRD positive or they're on cycle 2 and beyond, we skip the lower dose, the 9 microgram dosing, and we go right to the 28 micrograms per day, so no ramp is required. There's black box warnings for life-threatening CRS as well as neurotoxicity for this product. Another good reason why these folks are typically hospitalized for cycle 1. We have seen a decent amount of AST, ALT elevations, liver dysfunction in these patients as well. I think we had one a few weeks or maybe a couple months ago with a cycle 1, day 1 scenario. And then you have the other kind of concerns here, fever, infusion-related reactions, relatively common. Pre-medications include high-dose steroids and, of course, logistical issues regarding line maintenance and flushing. These patients are walking around with pumps with blinatumomab for 4 weeks. If you were to present to, an outside ER that wasn't familiar with blinatumomab, and they go in and they, the first thing they do is they get blood and they flush your line typically. If they were to flush this product through with the low dose that it is and how slow the infusion is, you could easily set off life-threatening CRS and infusion-related reactions. So these patients are asked to carry dosing cards and various instructions so that they can present to healthcare providers if they're being cared for in a center that isn't familiar with blinatumomab. But logistically, it's a very complex medication, but it is nice to have kind of this novel mechanism. And then one more bispecific engager, bispecific T-cell engager, emicizumab. This bispecific engager binds to and creates a bridge from factor 9 to factor 10, restoring the function of missing activated factor 8 for effective hemostasis. So, of course, it's approved for hemophilia A in the prophylactic setting. The dosing's here on the slide. Toxicities are on the slide as well, talking about things like antibody formation, injection site reactions, arthralgias, and it's prophylactic use. But as you can see here on the slide as well, it's relatively costly, almost $500,000 for year one with that higher dosing for the initial 4 weeks, and then almost $450,000 for year 2 and beyond. So again, this is for hemophilia A prophylaxis, a very costly medication, but still utilizing that bispecific engager monoclonal antibody structure in the upper right-hand side. So I did want to call it out as an FDA-approved product in hematology. Pivoting now to immune effector cells, or more specifically, chimeric antigen receptor T cell therapy, or CAR-T. CAR-T, the receptor is a special receptor that is created in a laboratory that is designed to bind to certain proteins on cancer cells, and that can be added to T cells to help them find and kill cells that have that specific protein expressed on their surface. To walk you through that process, basically, these CAR T cell products utilize these genetically altered patient cells, these genetically altered T cells that we collect from a patient. These CARs will grow and proliferate and engraft in a patient, and they can lead to active tumor cell kill, going after whatever that receptor is specifying, but also can promote immune surveillance to prevent recurrence of your disease. The most common disease that we have, or the most data we have, is in ALL, but these FDA labeling indications are expanding as we go. Wanted to walk through what this process actually looks like. In the upper right-hand side, we have leukapheresis. Patients' white blood cells are collected off or apheresed off using a large bore, almost dialysis-like catheter. These cells are shipped off to typically, I think most of the factories are near LAX, where these products are basically refined. The white cells are refined. We use a viral vector to insert whatever receptor, whatever CAR T receptor we're trying to express, whether that's CD19, whether that's BCMA, whether that's something investigational. These cells, after they've been implanted with these T cells, are expanded in vivo. They have a quality check process to make sure that these cells have picked up enough of the receptor, that they're viable, all these sort of things. They are shipped back to our center. We provide a little bit of lymphodepleting chemotherapy to kind of reduce the white blood cell count and help the body accept these reprogrammed cells. We will then infuse the CAR T cell products, and that will hopefully lead to tumor cell death, as well as CAR T proliferation, and again, surveillance throughout the body. We have, I believe, 6 FDA-approved products currently, 4 for CD19-directed products, and BCMA for 2. I'll go through all the names, as well as there's some specifics here on the slides for what they're approved for, pre-medications, as well as wholesale acquisition cost, or WAC cost. The first one, I believe, approved was Tisagen Lec-Lucel, or Kymriah. This was a CD19 product, or is a CD19 product, currently with indications for ALL up to 25 years old, relapsed refractory DLBCL, as well as relapsed refractory follicular lymphoma. The viral vector used to produce these cells is a lentivirus, and the cell dose is here on the slide. And Tylenol and Benadryl is going to be required for all of these products for pre-medication purposes. And we want to avoid steroids as a potential product that could attenuate or decrease the efficacy of these products. Number 2 on the slide here is axicabtagene ciloleucel, or Axicel, or Yescarta, CD19 directed as well. Labeling is relapsed refractory large B-cell lymphoma and follicular lymphoma. The viral vector here was a retrovirus, and then the rest of the slide has, of course, pre-medications and wholesale acquisition costs. We've got 2 more contemporary or more recent FDA-approved products. Bruxacabtagene autoleucel, or Tecartus, has labeling for B-cell ALL, relapsed refractory disease, as well as relapsed refractory mantle cell lymphoma. And then the final CD19 FDA-approved product is lisacabtagene maraleucel, or Breyanzi, CD19-directed product for DLBCL, primary mediastinal B-cell lymphoma, as well as follicular lymphoma. So those are the CD19-directed products. We do have 2 BCMA-directed products for our relapsed refractory multiple myeloma products, or patients. You have idacaptogene viclucel or Idacel, also known as Abecma, and then ciltacaptogene autoleucel or Carvykti. The product out of these two that we use currently at UW Health is the idacaptogene product, and I believe the ciltacaptogene product will be in play here at UW Health starting next year, if I'm not mistaken. There's a lot of big talk about these products' efficacies when they first were approved, and you have to remember that these patients, by and large in the clinical trials, were receiving these products after several lines, 3, 4, 5 products, refractory to chemotherapy, et cetera, et cetera. So any sort of response was quite significant. And they did bear out that way for a lot of patients, but not all of them. But these were kind of preached as kind of a big breakthrough where chemotherapy wasn't doing the job anymore, and these patients maybe weren't candidates for stem cell transplants. So any efficacy in this setting was considered to be a great thing. We do have, unfortunately, a decent amount of toxicity that's either possible or, in a lot of these drugs, almost certain. Insertional oncogenesis was a big concern. We haven't really seen a lot of this issue, but anytime that you're manipulating a product and then inserting it back into a patient, this should be something that we're surveilling or watching for. Neurologic toxicities with the CAR T products, confusion, delirium, aphasia, seizures, all the way through are big concerns. Cytokine release syndrome, which is classically seen with fever, fatigue, hypotension, tachycardia, nausea, capillary leak syndrome, as well as end organ dysfunction. You can have anaphylaxis or allergies in response to these technically foreign proteins, of course. And then something that's maybe not as well appreciated is on-target off-tumor toxicities. So we have CD19-directed therapies that are good for, targeting things like ALL, leading to death of that cell. But CD19 is not exclusive to malignant cells. So you'll have on-target, on CD19, but off-tumor, maybe it eradicates all your normal B cells, leading to pure B cell aplasia. Sure, it eliminated your malignancy as well, but we're going to have to deal with the downstream effects of that in addition. We'll talk a little bit more detail about the neurotoxicity as well as cytokine release syndrome, or CRS. CRS, again, is a constellation of inflammatory symptoms resulting from cytokine elevations. This happens with infused CAR T cells as well as with other immune cells responding to cytokines. The severity was correlated or has been correlated to increased levels of cytokines, peak ferritin and CRP levels in your patients, higher blood levels of these CAR T cells, as well as higher disease burdens. So the patients that come in with more disease are more likely to have CRS, or cytokine release syndrome. A nice breakdown of all the things that can go wrong with regard to CRS. We'll highlight things like the cardiovascular issues. We'll highlight renal dysfunction and GI issues, as well as prolonged issues with anemia, thrombocytopenia, neutropenia, B cell aplasia, kind of all the hematologic disorders. Even things like HLH and DIC are certainly possible with these CAR T cell products. We do have a UW guideline, of course we do, with regard to CRS and ICANS. This is a nice breakdown, just looking at the grading or the ASTCT consensus grades. These patients almost certainly, after receiving CAR T products, are going to have fevers and hypotension. It's very, very common. We would manage them in the same way we would do if someone was neutropenic and had a fever: antibiotics, fluids, cultures, all of those other things, making sure that we don't miss something. But by and large, this process is not something that's going to be fixed with antibiotics. But I did want you to see this and make sure that you're aware that we did have a UW guideline. Here's another nice example of kind of how we would manage this. Technically, the FDA labeling for these products are slightly different based upon what the product is and what the grading is. But to break it down kind of simplistically, grade 1, kind of just fever, maybe grade 1 organ toxicities. We're observing, we're ruling out infections, we're administering antibiotics, we're providing supportive care. Anything beyond that, we're going to start to get a little more advanced. Anyone who has hypoxia, hypotension requiring vasopressors, any grade 2 organ toxicity or more, We're talking about potentially administering tocilizumab, which is an anti-IL-6 monoclonal antibody. We're considering corticosteroids because we know that this is an inflammatory process that can be tamped down or attenuated potentially with corticosteroids. And as you go through the guideline and as you add toxicities and become more severe, you're talking about more tocilizumab, more corticosteroids, all the way up to dosing like methylpred a gram IV daily for 3 days. We have alternative IL-6 products such as ciltuximab, which can be used if no improvement in tocilizumab. A lot of times these patients just need to burn out their CRS and we need to give them time, but we also need to support them appropriately and give them appropriate corticosteroids. Once we get off guideline or off algorithm, things for the management of CRS or severe CRS get relatively weird. Whether that's high-dose Cytoxin, whether it's various other immunosuppressants that we're kind of just throwing at the product or the process to try and calm things down. We don't have great control of these products, and that's something that we'll talk about a little later as to what the next version of CAR T cells may look like. Immune effector cell associated neurotoxicity syndrome, also known as ICANS, is the very elegant name to be used for the neurotoxicity. The proposed mechanism is here on the slide, passive cytokine diffusion into the brain. We know this because there are higher serum levels of IL-6 and IL-15 that has been associated with ICANS. We also know that these CAR T cell products have been found in the CNS, so direct CAR T activation within the CNS may also be playing a role, but we really don't have a great handle on this mechanism quite yet. It can vary significantly from just a mild headache all the way to tremors, lethargy, seizures, obtundation, and it's relatively rare to see severe ICANS without at least a little bit of CRS. The ICANS grading here on the slide, I wanted to also ensure that you had seen this before, as well as, again, call out our guideline, as well as all of the package inserts will have this extensively within it. The pediatric grading, of course, is a little more difficult with pediatrics to assess things like, can you tell me where we are, what hospital we're at, who's the president, et cetera. So it's a little more tailored towards that pediatric population. And since this is a product that's used in pediatric ALL, it's good to kind of highlight this. Management for ICANS is really unsatisfactory, if I'm being honest. It's typically supportive in nature. We're treating things like elevated intracranial pressure and seizures per the standard of care. Tocilizumab really doesn't have a role with ICANS alone. Typically only used with concurrent CRS, no strong data supporting its use, again, with just neurotoxicity. And early steroid use is quite important. Now, when these products were first approved, we really thought that steroids were the death of them. And, you know, your $500,000 investment in a patient could go right out the window if you were using corticosteroids of any dosing. We were really very tremulous with regard to using steroids at all. Since then, we've really learned that there can still be efficacy here. There's still some benefit to these products. You really obviously want to minimize your steroid exposure as much as possible, but it's not the end-all be-all if they get some steroids. So we're becoming a little more steroid forward with these patients. And then to wrap up, I did want to highlight a little bit about the UW data that has come out. This was shared with the BMT program just a few weeks ago. I did want to highlight some aspects of it, and it'll be based upon the agent. So first up is axicabtagene ciloleucel, or Yescarta. This is highlighting our data for B-cell lymphomas. And then bottom, just to orient you, we have a comparison of UW data to clinical trials. So in the first column there, you have the ZUMA-1, which is a DLBCL or B-cell lymphoma product trial. And then in the second column there with some arrows is the UW experience with B-cell lymphomas. And I highlighted a couple things here on the bottom chart. CRS occurrence, 94% of patients in the ZUMA-1 trial, whereas we had only at 40%. Seems pretty low. This is an N of 10, so again, that's not a huge number, but it's something to highlight. And neurotoxicity was only seen in 2 of our 10 patients, whereas in the trial, it was assessed at 87% of patients. So that's somewhat interesting to know. Up on the tops of the slide, I did want to highlight again, 40% of our patients were transferred to the ICU or the TLC, which is interesting to know. Some of these patients received as many as 4 doses of tocilizumab. 4 out of these patients received corticosteroids, and 1 even required norepinephrine. And in our data, looking at some of the other things here, percent alive at 1 year, and again, and this is in a relapse refractory setting, but 55% or 5 out of 9 of these patients were alive at 1 year. So that's pretty good, including 2 of them had a complete response. So interesting data to pull out of UW. Again, relatively small N, but it's something that I think we should highlight and kind of continue to keep on our radar. Brexacaptogene autoleucel or Tecartus. We're talking about 7 patients in the mantle cell population in the upper top. We're talking about 3 patients in the ALL population in the second column here. They did note here that in CRS, the number of days to onset, 4 days, seems pretty long in our population. 8 days towards neurotoxicity, again, seems pretty long with regard to our patient population. I will highlight on the far right-hand side, we only had 1 patient get out to 1 year. He's passed away at this point. So 100% mortality at 1 year, but again, the N is very small. You can see at day 100, we're talking about 7 patients, and 50% potentially have a CR. So not as much confidence in our small numbers there, but I did want to, again, highlight those outcomes. With tisagenlecleucel or Kymriah, again, the product that we probably use the most at this point, we're talking about 18 patients here in the adult population. 83% of them did not have any neurotoxicity, which is interesting, I would say. Day 30 disease assessment for those 18 patients, we've got 28% of them have progressive disease, 38 or 39% of them have at least a PR. 1 of those, or I think 2 of those actually have a CR, so pretty interesting. And then again, of our 18 patients who received tisagenlecleucel, 55% of them are alive at 1 year. So pretty decent numbers here, I would say, in a relapse refractory population. Transitioning now to the multiple myeloma setting. So as I told you, our preferred product at this point has been idacaptogene or Abecma. We're talking about 10 patients here in this data. We have a nice disease response at 100 days here for our 8 patients, of which 3 of them had progressive disease. 1 had a CR, 1 had a PR, 1 was unknown. So I would say maybe this is a little more mixed with regard to our data, but again, it's difficult to call out too much with an N of 8. And then we did have on the bottom of the slide here, 60% of our patients received at least 1 dose of tocilizumab. 30% of our patients received at least 1 dose of corticosteroids, and those are pretty significantly over the KarMMa trial. So there is some pretty decent things here. Our neurotoxicity, again, smaller numbers, but it seems to be a little less than the clinical trial. Tough to tease much out of that, but it is interesting to see. And I would say we were pretty forward using with our tocilizumab in these idacaptogene patients. And anecdotally, as the pharmacist who typically runs with this team, these folks typically received a dose and didn't require additional ones. You can see that here on the slide. Only 1 patient needed more doses of tocilizumab. So it seemed like kind of a one and done tocilizumab thing. And there are trials ongoing with the use of prophylactic tocilizumab for CAR T cell products as well. So I've kind of alluded to it, how, at least from my perspective, these have been a little bit disappointing with regard to efficacy, as well as especially safety. But many ongoing studies are continuing to work towards a more safe and efficacious product. We're working on improving access to these products. Off-the-shelf or allogeneic CAR Ts would eliminate concerns over collection and viability. A lot of patients, or I won't say a lot, but many patients maybe can't collect off enough T cells to have this be functional. It also takes a long time to produce this, at least 20 plus days from collection to reinfusion. And once it goes to the lab and they're modified, sometimes patients don't have cells that can be modified to a significant level to be efficacious. So, you want a good yield of these cells being turned into CAR T cells. And that has been an issue with some of our patients as well. So if you could just take this and not have to deal with a patient's own collection, and you could go right to lymphodepletion and CAR T cell infusion instead of skipping that whole month-long process where it might not be viable, that would be a benefit to improve access to these therapies. Improving control would be good. Inserting something like a kill switch, aka a drug-inducible self-destruction. Something that's been studied is inserting an EGFR domain. And if the patient's having significant toxicities that can't be managed, maybe infusing a monoclonal antibody that targets EGFR to maybe cleave off these CAR T cell receptors from the T cells, and acting as a kill switch to stop these out of control CAR T cell products. Improving toxicities by improving on-target and off-tumor control. One example of this would be a dual CAR, so one that includes CD22 and CD19, to hopefully refine its targeting against malignant cells and keep it away from healthy, useful cells like your B cells to prevent things like B cell aplasia. And then, of course, we were looking towards improving proliferation and survival of these products, as well as microenvironment manipulation and tumor recognition. We've seen patients receive CAR T cell products and they're supposed to grow and produce and replicate, where they've actually just died off instead of replicating, and haven't been kind of a persisting thing for these patients. So we want to ensure that these products, when we're infusing them, are sticking around, doing the surveillance, and kind of giving us all of those extra benefits, not just kind of a one-shot scenario. That is an awful lot of content that I've gone through. I know that's very quick, but feel free to reach out if you have any questions or concerns. And of course, I'm typically on B66 if you'd like to stop by and talk about it as well. Thank you so much for your time.
What's the general shelf life for a CAR T product?